Hey everyone, my name is Dr. Jeff Yu. I'm a board certified emergency physician in both the USA and Canada, and today I'm going to be reviewing the Pitt Season 2 Episode 1, which is airing right now. I'm really excited about Season 2 because Season 1 was a very accurate representation of what we do in the emergency room on a day-to-day basis. I'll explain to you what's realistic and what's inaccurate. So let's get to it. So the first thing to note is that the date is July 4th. July 1st is when all of the residents and trainees graduate to a new level in the medical hierarchy. So that's when fourth-year medical students will graduate to become first-year residents, and first-year residents will graduate to be second-year residents. And with that becomes new responsibilities and new roles. So I expect that in the ER there will be a lot of new people that show up as well.
Up here, Joy. Ogilvy, off the chest. Clear.
Still VTAC, but it looks weird.
Agreed.
No pulse.
So this actually isn't VTAC. This is what we would call polymorphic ventricular tachycardia, or torsade de pointe. This is a shockable rhythm, which is why they're defibrillating the patient. The patient is pulseless. And typically what we would do is treat the patient with magnesium sulfate, because one of the most common reasons for torsade de pointe is if someone has prolonged QT on their ECG, which causes a phenomenon called R on T phenomenon, where you get a premature atrial contraction, and that causes a patient to go into a chaotic rhythm like this, where there's no beating of the heart.
We are sticking with the algorithm for now.
So what he's talking about is going through the ACLS algorithm for a pulseless ventricular tachycardia or torsade de pointe. And what they're going through is what we call the H's and T's, which are a list of reversible causes for cardiac arrest.
Rhythm's not working.
Faster and deeper, please.
You need a break, Joy?
No, I need an attending.
I'm right here. Stop compressions, we're calling it. Sorry, the patient's dead. All right.
So they were running a simulation, and this is actually very realistic. We run simulations like this in our emergency department as well. We would get all of our learners to practice things like closed loop communication, allow them to put these ACLS algorithms into practice so that they're being stressed and put on the spot and having to call the shots in a stressful environment, so that when a real patient comes in, they're able to use those skills to save a patient's life.
Your patient would have lived if you had pushed magnesium sulfate.
Good news is he's an organ donor. Chest.
Assault or accident?
Unclear. Initially had a pulse, lost it 2 blocks away.
So this patient has a penetrating trauma to the chest, and you can see that they're performing pretty low quality CPR as they're wheeling them in. This is actually kind of realistic because it is nearly impossible to do high quality CPR while a patient is rolling. That's why we've created robotic CPR devices like Lucas devices that do CPR for us, which literally just compresses the chest using a machine. And you can be confident that they're going to be pushing at the appropriate rate and the depth the entire time without any amount of human fatigue.
3. Prep for a left thoracotomy. I'm on it.
So a thoracotomy is a procedure where we make a big incision from the sternum all the way into the armpit in the 4th or 5th intercostal space, or right between in the ribs. And we would use a crank to actually open the ribs to spread it apart so that we could gain access to the heart or the lungs to try to identify where the patient was stabbed.
Stab wounds on the right. Why are we opening the left chest?
Better access if it's tamponade, and you can cross-clamp the aorta.
Cross-clamping the aorta is a procedure that we would do where we compress the largest vessel that as it goes down beneath the level of the diaphragms. And the rationale for doing that would be to cut off all of the circulation to non-vital organs and ensure that all of the blood stays circulating to the vital organs like the coronary vessels, the lungs, and the brain, as well as the kidneys.
This guy's dead anyway.
It sounds a bit crass for her to say that this patient's dead anyways, but she actually does have a point. If someone has a pulseless arrest due to a penetrating or even a blunt trauma, and you're having to perform a thoracotomy, the success rates of actually reviving this patient are somewhere in the range of 10 to 25%. And so, this kind of procedure is what we would call a true heroic measure. You treat the patient as if they are currently dead, and you're doing very aggressive interventions to try to bring them back to life.
I am in. Hook up the thoracil.
Want me to get that for you?
Not right now.
So they're spreading the ribs right now so that they can gain access to the heart. And typically what we would do is the patient would be intubated in their trachea, and we would actually push the endotracheal tube further down so that it goes down the right main stem, so that you're only ventilating the right lung, and the left lung would become deflated, and you would compress the left lung, move it out of the way so that you can gain easy access to the heart to see if there is any penetrating wounds to the heart.
You do these one-handed, pushing up against the breastbone, 4 fingers.
Very good.
So there's 2 different ways to do cardiac massage. Essentially, they're doing internal CPR. One way is to actually do chest compressions against the sternum by pushing it up. The other way is to actually hold the heart in your hand and to bring your palms together like this. You really want to avoid making a big rookie mistake, which is called surgeon's thumb, where you actually compress the heart like this, and you're compressing it so aggressively that your thumb goes through the wall of the heart and causes extra damage to the heart. So this is actually very accurate.
Not much blood to suction. Okay, team.
Samira, next steps.
Keep transfusing, open the right chest.
That is correct.
So what they're planning to do is what we call a clamshell thoracotomy, where we use a saw to cut through the sternum and extend that incision all the way to the right side of the chest wall and open up the chest wall like this. And the rationale for doing that is to identify if there's been any stab wounds to the hilum, which is the major vessels that supply the lung. And the only way that you'd be able to accurately assess if there was a hilar injury is if you do a clamshell to that side.
Booty's up that plan.
Heart's gonna need double compression, just like this. Squeeze from the apex to the aorta.
So this is a little bit inaccurate because it would be actually quite difficult to cut through the sternum just using trauma shears or the scissors. Typically what we have is a wedge type saw that you hammer through the sternum, but it is accurate that they are cutting through the sternum to free up that space to open up the chest wall like that.
Hardly any hemorrhage on the right.
Looks like the flip worked.
How's the heart working? Feels full of blood. First time since we started.
Hold compressions.
So you can see the heart kind of fibrillating there. So the first thing that I would think about is ventricular fibrillation, which can happen if the heart has been starved of oxygen and nutrients for a prolonged period of time, like if the patient was in cardiac arrest from massive blood loss. So typically what we would do is use internal defibrillators, which are kind of like paddles to shock the heart at a lower dosage of voltage than we would with the external defibrillators.
That's what normal sinus looks like. Strong carotid. Saline lap pads and up to the OR.
So now they've achieved what we call ROSC, or return of spontaneous circulation. The next priorities at this point, after someone has been in cardiac arrest for that prolonged period of time, is to assess their neurologic status. So you would go to check their pupils to see if they're fixed and dilated. You would check to see if there's any response to painful stimuli. You would also send them for a CT scan of their brain to see if there's any signs of anoxic brain injury or brain injury due to the brain being starved of oxygen. The patient would obviously still go to the operating room as well because the patient has an open chest, and you know, we would need to do definitive management to fix the bleeding lung. And typically what would be done is a lobectomy, where you chop out the portion of the lung completely that has that injury if you aren't able to identify specifically where that the puncture is.
Lynn, nice to meet you both. I'm a new grad RN here to shadow.
Welcome to the Pitt, Emma Nolan. Here, let me put some of your stuff behind the desk and I'll give you a quick tour.
Okay.
So this is actually very accurate as well. We have a lot of student nurses and new medical students that come with a lot of different equipment in their breast pocket, in their pouches, that could be used as weapons against them. Like, she was carrying scissors in her pocket, as well as some like different pens. Another big mistake that we see is nurses or medical students wearing lanyards because sometimes lanyards can be used as a choking device by patients. So what she's doing right now is she's removing all of these sharp objects from the student nurse's pockets so that she has a lower chance of being assaulted with those as a weapon.
Where from, sweetheart?
Sault Ste. Marie. It's in Upper Michigan, practically Canada.
My great-grandmother was from up that way. Nice area. A lot of bugs. How about a cup of cold?
So I work in the downtown core of Vancouver in the inner city, and this is actually very accurate. We have a lot of unhoused patients that come into the ER that do not smell very good. And, not only because of dirty casts and soiled clothes, but in the waiting room you can have people that are sitting in their own urine and feces, people that are vomiting into bags. So this can make the waiting room smell really, really bad. Typically what we do in my emergency department is if we have an unhoused patient that is very dirty like that, we would take them straight to our patient decontamination shower. We would take their clothes off, give them a good scrub down. We would also give them permethrin cream and shampoo, or Nix shampoo and cream, to help eradicate any lice or bug infestations. And then we would give them fresh clothes and send them on their way if that's the only issue that they're coming in with.
Shower.
I just drive them. I'm not a wash and detail service.
Yeah. God forbid you prove useful. Good time in the summer. Time for you and me to do.
This is realistic as well. I mean, the smells are sometimes awful. I think the one thing that they could have improved on to make the patient less embarrassed is not to make it as noticeable that they're uncomfortable with the patient's smell. So one of the strategies that we use in the ER is to use flavored chapstick and to rub the chapstick on the inside of a mask. You put the mask on, and instead of breathing in all of the smells of the vomit, stool, street feed, all these different things, you'd just be breathing in the flavored air of the chapstick instead.
And I'm solo this weekend. I need to get laid.
This is actually quite realistic. Yes, the emergency room is a very intense place where we're dealing with life and death, but a lot of times when we're charting or sitting at the nursing station, we will be shooting the shit with the nurses and the doctors and the residents, talking about our personal lives, sharing black humor. Conversations like this happen all the time between patient encounters.
It's a little much before 8 a.m., right?
Yeah. As soon as we can. Any questions?
No, I'm just her dad's girlfriend, so I'm new to all this.
No worries.
Okay, so they're saying that this is the dad's girlfriend, and I wonder if they're introducing this person as the dad's girlfriend because there's going to be an element of non-accidental injury. We'll see. That's typically what we see in the ER is patients are brought in by the stepmother, stepfather, or the girlfriend or boyfriend, and statistically that is one of the highest risks for non-accidental injury or child abuse.
Okay, big breath. All right, lungs sound great. Can you lean forward for me?
Ooh, so this patient has an old bruise on her back. And this would immediately make me think of non-accidental injury or child abuse. The things that I would be wanting to investigate her for right now is I would probably send her for a chest x-ray to make sure that she doesn't have any rib fractures. I would also want to collect a urine sample to make sure that there's no signs of a blunt kidney injury, and also do a full head-to-toe survey with all of her clothes off to look for any other injuries that we might have missed. And I would probably also consult the Child Protective Services if I was concerned about child abuse or non-accidental injury.
Well, with the bruise on your back, we need to check your urine.
There we go. So they would check the urine and check for any signs of blood, because that would be an indicator that there's blunt kidney injury. There it is, gross hematuria. She probably has a blunt kidney injury.
Take a sabbatical. Leave tonight.
Where you going?
So this is quite realistic as well. Most emergency departments have a sabbatical program because emergency medicine is one of the highest stress and highest burnout professions in the medical world. My emergency department, for example, has a sabbatical program where you get 1 month of dedicated time off every single year. Some people will use that for research. Some people will do it for quality improvement or teaching. But I think most people use it just to travel, spend time with family, and just get their mind completely off of medicine, so that when they return, they come with a fresh perspective and they don't feel burnt out. And this is really important for longevity in the game.
I appreciate that, Louis. That's not really the point, but need to lift up your shirt for a second.
Oof. So this guy clearly has tense ascites. He's got a very distended abdomen. He's got bulging veins and a bulging umbilicus or a belly button. So this would make me immediately think that his belly is filled with fluid from alcoholic liver cirrhosis.
How long has your belly been hard like that?
I don't know. I figured I could wait another week.
You need some lab tests and a procedure to drain off some of this fluid.
The procedure that he's referring to is called a paracentesis, where we stick a needle directly above the pelvis to drain off fluid, to take tension out of the belly. Because when you have enough fluid that's built up over there, it can actually prevent the diaphragms from moving down, and this can cause shortness of breath.
Yeah, I know the drill. I've been tapped a few times before.
3 times in the last 6 months. You need to give your liver a break, Louis.
Yeah, I know.
Alcohol is one of the most dangerous drugs out there. We see so many complications of chronic alcoholism, not only with liver failure and tense ascites like this, but people that fall and have brain bleeds, get into bar brawls, crash the cars, kill themselves, kill other people. I don't think that the general public really knows how bad alcohol is of a drug, and it's one of the reasons that I've stopped drinking completely after working in the ER.
It looks pretty quiet to me.
Oh no, he said the Q word. That's one word that you don't say in the emergency department. People tend to be quite superstitious, and if you say the Q word, which is quiet, or it's a full moon, people tend to believe that you will get a flood of very sick or bizarre patients. So it's just like one of the weird things of the emergency department.
Huh.
Oh, there it is.
Like I said, come on.
I know you think it's silly and petty.
No, I think it's just kind of endearing, pretty damn accurate.
So this kind of tension is actually quite accurate in the real emergency medicine world. And the reason for that is because emergency medicine is one of the newest medical specialties out there. And a lot of the older physicians and some of the newer physicians actually believe that calling the emergency department nicknames like the ER or the emergency room or the Pitt will take away from the credibility of emergency medicine as a specialty.
Let's think about reversible causes of confusion in the elderly.
So what he's referring to is DIMS mnemonic. So it's 4 different major factors that can cause confusion in the elderly. So the first one is D, drugs. That can be inappropriate doses of the current medications that the patient is on, or other substances like alcohol, opioids, or benzodiazepines can cause a lot of confusion. I is infection. So the most common sources of infection are the lungs with pneumonia or the bladder with a urinary tract infection. M is metabolic, so we would do blood work, including a full metabolic profile, looking at their electrolytes and their kidney function to rule that out as a potential cause of the confusion. And last, S, which is structural, we would do a CT scan of the brain to make sure that the patient doesn't have something like a tumor or a bleed. That's.
He looks so peaceful.
Should we go find a new patient?
No, stay here.
So I like what he did there by getting his junior learners to stay there and bask in that, I guess, the discomfort of watching this patient pass away. Seeing your first patient die is a very uncomfortable moment. And the early that you get exposed to that, the better you'll do in the long run in the medical profession, because you can't save everyone. In this particular case, this patient did not want to be saved with heroic measures like CPR and intubations. So I think that he's doing the right thing by getting his junior learners to stay there and watch this patient pass away peacefully.
Is to take a moment of silence when we lose a patient, to respect their humanity. He was someone's son, perhaps a father himself, a brother or friend.
So this is a proud daddy moment for Dr. Robbie. You know, I've had these moments as well in my career where you see some of your learners adopting some of the softer skills in medicine, where you're able to empathize and be compassionate for the patients that you're caring for, and they're passing those skills along to the learners beneath them as well. So good job to Dr. Robbie, and good job to this young doctor as well.
Physician.
That's it? Every emergency medicine doc gets sued sooner or later.
This is absolutely true. It doesn't matter how good of a doctor you are, you will get sued or you will get a complaint to the hospital or the college at some point in your career. It's incredibly stressful, and it is a bit of a numbers game, because even if you haven't missed any diagnoses, sometimes you can get complaints for very random things. So to give you an example, my first college complaint was when I was maybe in my second or third year as an attending, and it was from a patient that I saw for a kidney stone. She came in with severe flank pain. I sent her to the CT scanner. I accurately diagnosed her with a kidney stone, put her on the correct medications, and referred her to a urologist. And then months later down the line, she actually submitted a complaint to the college saying that when I sent her to the CT scanner, all of her data was downloaded from her body and sent to all the telecom companies throughout the country, and that we were injecting data into her body through the scanner. And so, you know, there was likely some mental illness that played into that case, but it just goes to show that you can do everything right and you can still get these complaints, and these complaints can drag on for years. You know, this case that I was involved in, I had to keep responding to different letters to the college and to this patient over a course of about 2 years. And that entire time, it's very, very stressful. It can really erode a doctor's confidence and leads to a lot of burnout.
Seriously, don't sweat it. I mean, you're still a resident. We're protected by the hospital. You could cut somebody's head off and get away with it.
You know, she actually has a point. The reality of working in an academic center is that if a resident or a medical student makes a mistake, they would likely get off scot-free, because the buck stops with the attending. It's our job to observe and monitor these learners to make sure that they're not missing any diagnoses, that they're not, you know, inappropriately doing interventions that aren't warranted or harming the patient in the process. And if those mistakes happen, then and a lawsuit was launched or a college complaint was launched, it would actually fall on the attending doctor. Not
A few cookies? How many are you eating in a day?
Probably a dozen or so, but they're not very big.
So what they're alluding to is cannabis hyperemesis syndrome. We see this quite a lot in Vancouver because weed culture is very prominent on the West Coast. So what we commonly see is people who smoke a lot of cannabis on a daily basis or use a lot of cannabis products, whether it's vaping, oils, shatter, eating edibles. The THC can actually build up in your fat deposits around your body and cause recurrent episodes of cyclic vomiting. The classic symptom that would point towards a diagnosis of cannabis or cannabinoid hyperemesis syndrome is if the person keeps going into hot showers to alleviate the symptoms of nausea and vomiting. And the reason why hot showers typically work is because the heat signals in the skin tend to distract from the nausea signals to your brain. One way that we can replicate the hot showers is by applying capsaicin cream onto the abdomen, chest, and back. And in the ER, we would typically treat this with anti-nausea medications like ondansetron and Gravol. We would also give an antipsychotic medication like Haldol or haloperidol to help with the cyclic vomiting. That was it for season 2, episode 1. Amazing show so far. Very representative of what we do in the ER every single day. And a lot of the fine details of the interactions between staff in the ER, some of the hierarchies that exist within the medical system were very well represented here. I thought that the way that they depicted the penetrating trauma, the thoracotomy, and all the things that we think about and manage in a critically ill patient like that were very well represented here. So very well done to the Pitt. If you thought this video was helpful, informative, or interesting, please give it a like, leave a comment, and subscribe to the channel. And I'll be watching every episode as it goes along through the season to kind of share my insights from real emergency medicine. So thanks so much for watching, and I'll see you in the next one.